It's day 2 of NEI Synapse, and we are here with Dr. Cutler for an extended Q&A session. Let's listen in as he addresses your unanswered questions from today's presentation.
I just presented a talk on tardive dyskinesia here at the NEI Synapse meeting, and I wanted to answer some additional questions that came in from the audience. Very often we don't get to all the questions, so this is a nice format to do that. So my first question is, do you have to give tetrabenazine with food? And that is one of the two newer VMAT2 inhibitors that are FDA approved to treat tardive dyskinesia. The answer is yes, tetrabenazine is recommended to be given with food for better absorption. Next, can you clarify, is cogentin or benztropine okay for medication-induced TD? And the answer is a resounding no, absolutely not. Cogentin is not only is it not effective for TD, it is contraindicated for TD. Benztropine and other anticholinergic medications are approved and useful for acute drug-induced movement disorders, which is Parkinsonism, akathisia, and dystonia, but not for TD. Can we use these new VMAT2 inhibitors in a pediatric population? Well, neither valbenazine nor tetrabenazine have been formally studied in the pediatric population for tardive dyskinesia. However, clinical trials are going on for Tourette syndrome in children, so we will have more information on the safety and efficacy in the pediatric population. But what I would say is, certainly you have to use your clinical judgment. They're not FDA approved. However, so far preliminary safety evidence from these Tourette syndrome studies have been very good, and I would say that probably it is reasonable to consider using them in the pediatric population. Amphetamine blocks VMAT2 and increases synaptic dopamine, but VMAT inhibitors block VMAT2 and do not increase a synaptic dopamine. How do you explain this difference? Well, amphetamine actually does something interesting. It not only blocks VMAT2, it actually reverses VMAT and then pumps out dopamine. So that's a unique mechanism to amphetamines that VMAT2 inhibitors do not do. So they're not pumping out more dopamine, they're simply blocking the amount of dopamine coming into the vesicles and therefore less dopamine available to be released into the synapse. All right, here's a very interesting question. What happens to the excess dopamine in the presynaptic neuron when it is blocked from going into vesicles with the VMAT2 inhibitor? Can this cause problems? That is a really important question. And what happens is there is monoamine oxidase enzymes, not only on the outside in the synapse, but also monoamine oxidase is found inside nerve cells. And so the excess dopamine is degraded by monoamine oxidase. We don't know, however, if something is done before the dopamine is degraded. So that's an area actually of some interesting study. But the thinking is at this point that it's simply degraded by monoamine oxidase inside the cell. Can you make a comment about the abundance of non-psychiatrists prescribing quetiapine for sleep without evidence of psychosis or bipolar disorder and the liability of TD? Well, this leads me into a more general comment I'd like to make, which is all of the atypical antipsychotics, while we think they may have a lower risk for TD, are certainly not free of risk, including quetiapine, which has a relatively low affinity for the D2 receptor. And so it really behooves us to be very careful and do a careful risk-benefit assessment, including considering the possibility of tardive dyskinesia before we prescribe these medications, particularly for mood disordered patients, such as those with depression or bipolar disorder, and certainly before using a medicine like Seroquel simply as an aid for sleep. So I think it's important to always do a careful risk-benefit analysis. However, these medicines, let's not forget, are extremely effective, and mood disorders are extremely difficult conditions to treat and can cause significant morbidity and even mortality. These people can commit suicide. So these are very effective medications that do have potential risk. And the most important thing also is if you're using them is to do informed consent about the possibility of movement disorders such as TD and to regularly monitor for movement disorders, including something like the Ames scale. Okay, what if the patient is able to control the movements while you're doing the Ames exam, but you observe them during the appointment? Well, the point is, and that is true that they sometimes can suppress a little bit, but the point is when you're scoring the Ames, you take into account all movements that you see at any point during the time that you're with the patient. So one of the things you want to do is to try to maybe get a look at them when they don't know that you're watching them in the waiting room, or walk with them from the waiting room to the office and watch. And if you see movements at any point during the evaluation, not just during your quote formal Ames test, that gets scored on the Ames. Next question. Our institution uses discus. The discus is another movement disorder rating scale. Is this an adequate TD screening tool? The answer is definitely yes. The discus is, like the AIMS, this is a different rating scale that is often used. Now, these scales are not diagnostic scales for tardive dyskinesia, but I like how the person said screening tool. These are scales that can alert you to the presence of abnormal movements, and then you, of course, need to do a differential diagnosis as to where they're coming from. And you then can use these scales, either the discus or the AIMS, to monitor the movements or to monitor for the emergence of movements and to decide if you need to do something about it, such as starting a VMAT2 inhibitor. The AIMS is just used more widely. It's more commonly used, but the discus is also quite good. The next question is, help me to distinguish tic disorder exacerbation in a patient with diagnosed tic disorder versus the development of TD in a patient on risperidone. Well, this is a very difficult differential diagnosis, and you need to know a lot more information, of course. Did the person have tics prior to starting risperidone, and now on the risperidone have the tics changed in frequency or character? Because it is possible that you can have both tics and tardive dyskinesia. All right, what is the recommended treatment for tardive tremor, and is it possible to have both tremor and TD? The short answer to that one is yes, you can have both. You can have TD and Parkinsonism, actually, and that's a difficult situation. Is there a situation where it is appropriate to use both an anticholinergic and one of the VMAT2 inhibitors? The answer is yes, and this is the exact situation. And if you're not comfortable with this is definitely one of the situations where referral to a neurologist, ideally a movement disorder specialist, would be very reasonable. What if you take a patient off benztropine and they swear things are worse? Well, that's certainly possible because there is the potential of rebound and withdrawal. So I would take patients off benztropine very, very slowly and carefully. And I think the point of this is that if this person actually has tardive dyskinesia, benztropine is not helping, it's not effective, and can make it worse. So really, the VMAT2 inhibitor is what you want to do if you have a tardive abnormal movement. Benztropine and anticholinergics are for acute drug-induced movement disorders and for short-term use, because if you see an acute drug-induced movement disorder, particularly with the atypical antipsychotics, they are dose-related, and you should lower the dose, and they should get better, or sometimes with time, such as with akathisia, sometimes we see adjustment and getting better. So the point is that benztropine and anticholinergics typically are for more acute use and not for chronic long-term use, except in some situations where you do feel like there is a tremor or something that could respond to it longer term. So I'm not being an abolitionist and saying never use it. I just would like people to use less of the anticholinergics. Let's remember the side effects of anticholinergics, particularly in older patients, can be very bad. You can get not only dry mouth, but you can get urinary retention and constipation, and you can get, of course, confusion or memory loss, so cognitive impairment. Okay, and finally, if a patient is on a second-generation antipsychotic and also abusing methamphetamine, are they at high risk of TD compared to a non-meth abuser? And the answer is yes. One of the risk factors for tardive dyskinesia is concomitant substance abuse, and I would say probably in particular amphetamine or cocaine, which are really damaging to the dopamine system in particular. So these are people who are going to have abnormal dopamine systems, and it is apparent that they do seem to have a higher risk of tardive dyskinesia compared to non-substance abusers. Well, these were terrific questions, and I really want to thank you for your questions. And please stay in touch with us, interact with NEI through the website, neiglobal.com. Thank you so much.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Synapse, and make sure to subscribe.